Sleep, every patient wants it, and when they cannot get it, they come to us. Today on RxRasha Pharma Basics, we are covering medications for insomnia, the complete guide, Z-drugs, ramelteon, benzodiazepines, orexin receptor antagonists, and low-dose doxepin. By the end of this episode, you will know how each one works, when to use it, and how to counsel your patients with confidence. Insomnia is defined as difficulty falling asleep, staying asleep, or waking too early, at least 3 nights per week, for at least 3 months, causing daytime impairment. It is not just about feeling tired. Untreated insomnia is linked to depression, anxiety, cognitive decline, hypertension, and increased cardiovascular events. Quality of life, workplace performance, and accident risk all suffer. Before we reach for a prescription, the first-line treatment is cognitive behavioral therapy for insomnia, CBTI. Pharmacotherapy comes in when CBT1 is unavailable, insufficient, or used alongside it. The Z drugs, zolpidem, zaleplon, and eszopiclone, are non-benzodiazepine hypnotics. Despite their different structure, they work on the same target as benzodiazepines, the GABA-A receptor. They are positive allosteric modulators, meaning they enhance the inhibitory effect of GABA, increasing chloride influx, suppressing neuronal activity, and inducing sedation and sleep. The key difference from benzodiazepines is more selective receptor binding, which generally means fewer side effects. Zolpidem is the most prescribed hypnotic in the world. Onset is 15 to 30 minutes. Available in immediate release for sleep onset and extended release for both onset and maintenance. The dose differs by sex, 5 mg for women, 5 to 10 mg for men. Women clear zolpidem more slowly, leading to higher next morning levels. Zaleplon has the shortest half-life, approximately 1 hour. This makes it uniquely useful. It can actually be taken in the middle of the night if the patient wakes and has at least 4 hours remaining before they need to be up. Eszopiclone has the longest half-life of the 3, about 6 hours. It addresses both sleep onset and sleep maintenance, and it is the only Z drug the FDA has approved for long-term use without a time limitation. The Z drugs are effective, but they come with real risks. Tolerance and dependence develop with prolonged use, particularly with zolpidem. If you stop abruptly, rebound insomnia can be worse than the original problem. Always taper after extended use. Next morning impairment is a documented concern, especially with extended release zolpidem. The FDA mandated lower doses for women specifically because of slower clearance and higher sedation risk the following morning. Complex sleep behaviors are rare but serious. Sleepwalking, sleep driving, sleep eating. The FDA issued a black box warning for this class. In the elderly, Z drugs increase fall risk, confusion, and fractures. Always use the lowest effective dose and avoid long-acting formulations in this population, and never combine Z drugs with opioids or alcohol. Respiratory depression is a real risk, especially in patients with sleep apnea or COPD. Ramelteon works in a completely different way. Instead of targeting GABA, it activates MT1 and MT2 melatonin receptors in the suprachiasmatic nucleus, the brain's internal clock. This shifts the circadian rhythm and promotes natural sleep onset. No sedation, no GABA, no dependence, and no controlled substance classification. The dose is 8 mg taken 30 minutes before bed. It treats sleep onset only. It does not help with sleep maintenance. But what makes ramelteon especially important in practice is the patient population where it shines. Patients with a substance use disorder history, ramelteon is your first choice. Elderly patients where fall risk is a concern, ramelteon is preferred. Patients where a controlled substance creates regulatory or safety issues, ramelteon. Side effects are minimal, mild dizziness, fatigue, and rarely elevated prolactin levels. Benzodiazepines also enhance GABA A receptor activity, but they are less selective than Z drugs. They bind multiple receptor subtypes, which gives them a broader pharmacological effect, stronger sedation, anxiolysis, muscle relaxation, and anticonvulsant activity. But that also means more side effects and a higher risk profile. The three most commonly used for insomnia are triazolam, temazepam, and estazolam. Triazolam has the shortest half-life, 2 to 5 hours, used for sleep onset. Temazepam, with a half-life of 8 to 20 hours, is better for sleep maintenance and is the most commonly prescribed benzodiazepine specifically for insomnia. Estazolam sits in between. All three are Schedule IV controlled substances. All carry the risks of dependence, withdrawal, rebound insomnia, anterograde amnesia, and respiratory depression. Avoid long-acting benzodiazepines in elderly patients entirely. For chronic insomnia, benzodiazepines are not the preferred long-term solution. Now, the most exciting pharmacological development in sleep medicine in decades, dual orexin receptor antagonists, DORAs, suvorexant and lemborexant. Here is what makes them fundamentally different. Every drug we have discussed so far sedates the brain. DORAs do not sedate, they block wakefulness. Orexin, also called hypocretin, is a neuropeptide that keeps us awake. It does this by activating two receptors, OX1R and OX2R. DORAs block both of these receptors simultaneously, switching off the wake-promoting signal and allowing sleep to occur naturally. The result is sleep that feels more like natural sleep and less like pharmacological sedation. Both DORAs are approved for sleep onset and sleep maintenance insomnia and are Schedule IV controlled substances, but there are important clinical differences between them. Suvorexant starts at 10 milligrams with a maximum of 20. It is taken 30 minutes before bed. Half-life is approximately 12 hours. At higher doses, next morning somnolence can be a concern. Lemborexant starts at a lower dose, 5 milligrams, maximum 10. It has a faster onset and a longer half-life of 17 to 19 hours. Studies show lemborexant has an edge in sleep maintenance with less next morning residual effect compared to suvorexant. For most patients, lemborexant's profile gives it a slight clinical advantage, particularly in the elderly at the 5 milligram starting dose. Both DORAs should be avoided in patients with narcolepsy, as orexin signaling is already deficient in that condition. Low-dose doxepin is one of the most interesting sleep medications in clinical practice, not because it is new, but because of how it is used. Doxepin is a tricyclic antidepressant. That is its structural class, and it remains so at any dose. At the full antidepressant doses of 75 to 150 milligrams, it works through multiple receptor pathways, but at 3 to 6 milligram, which is the FDA-approved dose for insomnia, the dominant clinical effect shifts almost entirely to potent and selective histamine, H1 receptor blockade. This prolongs total sleep time, particularly in the maintenance phase, with minimal anticholinergic burden at these low doses. It is important to note that doxepin at 3 to 6 milligrams is a Schedule IV controlled substance, the same classification as Z drugs and benzodiazepines. It is not exempt from controlled substance regulations simply because the dose is low. The dose is 3 milligrams for elderly patients and 6 milligrams for adults. It should be taken 30 minutes before bed with at least 3 hours of fasting beforehand to avoid delayed absorption. Avoid doxepin in patients with narrow-angle glaucoma, benign prostatic hyperplasia, or urinary retention. Even at low doses, the antihistaminic and mild anticholinergic effects can worsen these conditions. The clinical advantage of low-dose doxepin is its specific indication for sleep maintenance insomnia, its well-established safety profile at these doses, and its particular usefulness in elderly patients who wake repeatedly during the night. Now let us put it all together. How do you choose? For sleep onset insomnia, your options are zolpidem immediate release, zaleplon, ramelteon, or a DORA. For sleep maintenance insomnia, think eszopiclone, temazepam, suvorexant, lemborexant, or low-dose doxepin. If your patient has a substance use disorder history, ramelteon is your first choice, followed by low-dose doxepin. For elderly patients, start low. Ramelteon, doxepin 3 mg, or lemborexant 5 mg are your safest options. Long-acting benzodiazepines should be avoided entirely in this group. For short-term use, zolpidem, zaleplon, triazolam, and temazepam are all reasonable choices. And across all hypnotics, always avoid combination with alcohol, opioids, or other CNS depressants. This slide gives you the complete class-by-class reference. 5 drug classes, 7 clinical parameters. Use it as a quick reference at the point of care. The key takeaways: benzodiazepines carry the highest dependence risk and should be avoided in the elderly. Ramelteon and low-dose doxepin are the only, if your patient has a substance use disorder history. DORAs offer a favorable safety profile with a natural sleep feel, and eszopiclone is the only Z drug approved for long-term use. Before we close, 6 clinical pearls to carry into practice. 1. Zolpidem dosing is sex-specific. 5 mg for women, 5 to 10 for men. Women clear it more slowly. 2. Zaleplon is the only hypnotic that can be taken in the middle of the night, as long as 4 hours remain before waking. 3. Eszopiclone has no FDA time limit. All other Z drugs are recommended for short-term use only. 4. In elderly patients, avoid long-acting agents. Zolpidem ER, eszopiclone, and temazepam significantly increase fall and fracture risk. 5. For patients with substance use history, ramelteon or low-dose doxepin. 6. Z drugs and food do not mix. Food delays absorption and reduces peak effect. Always counsel patients empty stomach immediately before bed. Insomnia is common, but the pharmacology behind treating it is not simple. 5 drug classes, 5 different mechanisms, 5 different risk profiles, and the right choice depends entirely on knowing your patient. This is Rasha with RxRasha Pharma Basics, real pharmacology, taught the way you will actually use it. If this episode helped you, share it with a colleague who needs it. And if you are not subscribed yet, hit subscribe now so you never miss an episode. New content every week.